Sri Priya, welcoming you to the 19th session of our foundation course in palliative medicine. With only one more session to go, today we are discussing about opioid availability. And we have the apt personality to take us through the session, none other than Dr. M.R. Rajagopal, who has contributed a lot, as you know, in sensitizing the issue across the medical field. So, since he has interacted with this cohort earlier, also, I welcome back Dr. Rajagopal to this session. Sir, it is our pleasure to have you with us again, sir.
Hi.
Oh, over to
Hello,
you,
everybody.
sir.
Thank you, Sri. How are you all? We have people from different countries, I know. The rules and regulations that I am going to talk about may be applicable mainly to India, but the way these things are overcome could be a matter that's of interest to everyone. So, we as a group have learned palliative medicine. Many of you were already aware of it. To some of you, it was a new subject. Over these last many weeks, you have acquired a lot of knowledge. Armed with all that knowledge, you try to relieve the pain of a patient. Say, with severe cancer pain. And then you find that you do not have access to the right medications. You do not have access to opioids. This is a story that's common to most low and middle income countries. High income countries generally have solved the problem except for the Gulf countries. And possibly they have another problem there, abuse of the drugs. But we are going to talk about balanced access to opioid medicines. I will start by sharing my screen and showing you a message and an image that you have seen before. Reminding everybody that health is not only absence of disease or infirmity, it's physical, social, and mental well-being. To a man in pain, we have to make him feel better. And our duty of care, as defined by bioethics unit of ICMR, is to mitigate suffering. There exists no exception to this principle. You and I have a responsibility to mitigate suffering. Let us keep that at the back of the mind. And when you confront a man like this, if you do not have the right opioids, what will you do? You do not have access to morphine or other step 3 opioids. Will you say, sorry, I'll just give you some tramadol, which you know will not be anywhere near halfway as effective as necessary for this man? What will you do? You are a doctor. You are trained as a doctor. So far, it is possible. It is possible that so far you have not considered it your duty to make medicines accessible. But if you don't make the medicines available, unfortunately, you will be failing as a doctor. You will be failing in your duties to mitigate suffering. Therefore, you are all champions. You are all coming into a new field. In any pioneering field, it becomes our duty not only to be a clinician, but also to be an advocate. It was Virchow, how do you pronounce that? Virchow, the ancient physician. He said, the physician is the patient's natural attorney. We have to be advocates for people in pain. We not only need to learn to assess and treat pain, but also to make this available. You try, you ask for morphine and you find there are 43 different problems, objections brought out. This is something that we want to solve. And this session today is going to talk about what could be the barriers. Where could the objections come from? How can we solve them? First, let us start by accepting the principle of balance. Hey, ladies and gentlemen, those who have not switched the video on, please switch the video on. At least by photograph, let me connect with you. Most of you have, I know, but for those who have not, please do. The dual principle of balance says that we have a dual responsibility. I put this first. I don't want my grandchildren to be subjected to drug dependence. We need to prevent non-medical and inappropriate use of opioids. We also need to make opioids available for those in pain. Both are our duties. So we will try to obtain the opioids and make them available, but it needs to be safe and it needs to be uninterrupted. In the minimum standards or palliative care units created for India, this is the first condition: safe and uninterrupted access to opioids for pain relief. But I particularly highlight the safety part of it also. You cannot just say, okay, let them do whatever they want. I'll just prescribe the opioids. That will be hazardous because 1 month from now or 1 year from now, you may find a problem on your hands when the drug inspector comes for a check, or the newspapers come out with a story about how the drug is abused. So we, to be able to do justice to people like him, we need to be able to assess the barriers. What are the barriers that you have, and take remedial measures. We have to ensure proper documentation. We have to advocate for access to pain relief. Class sorry about that. For India, this was a big obstacle. You see how huge the book is? Narcotic Drugs and Psychotropic Substances Act. This was a major barrier. So we needed to overcome the barrier. Fortunately, with a lot of work done by a lot of people for 19 years of efforts. Lesson 1, persistence. Many things will be difficult. Don't give up. Sometimes you have to withdraw and go through another angle. But if we give up, we lose. These are barriers that can be sometimes forbidding. In India, this major obstacle was solved in 2014. So what did the change in law do? I mean, for those from other countries, please note, you may have your own kind of barriers. Which other country is represented here? Sri Priya, do we know?
Sir, one participant from Indonesia, I guess, Dr. CV.
Okay. Uh, so maybe in, I have seen the system in Indonesia many
Sorry,
years back.
I'm from Malaysia. I'm from
Okay,
Malaysia.
Malaysia
Sorry
has,
for that. So extremely sorry
No
for that.
problem. It's okay.
okay.
Yeah.
Malaysia has more or less sorted this out. Malaysia has reasonable access to opioids, as far as I know. So, Dr. CV, maybe what something of that I am talking about may not be relevant to you, but one thing is relevant to you also. That is the emphasis on safety. and uninterrupted access. It will be interesting for you to know what the barriers were in this country. Till 2014, according to the old law, every institution needed multiple licenses. When I first wanted to make it available, and subsequently, I first needed to get a possession license. This involves at least 3 government officers, sometimes 4 and 5. They all have to connect together. You know how our bureaucracy is. So you need a possession license, which will allow you to possess a certain medicine in such and such a formulation. If you have morphine injection mentioned there, you cannot buy tablets. Then after getting it, you had to get an import permit, as if we are importing from another country. This is to bring it from one state to another, you need an import permit. For the manufacturer to send it from Maharashtra to Kerala, he needed to get an export permit. Now, these licenses have limited validity. And in many states, not in Kerala, but say in Tamil Nadu, many other states, to take it from one city to another, you needed a transport permit. And all these needed to be valid at the same time. I have had this problem. With a great difficulty, I get the possession license and import permit. The manufacturer has a delay getting the export permit. Eventually, he sends the consignment. By the time it has arrived, I find that the validity of import permit expired the previous day. I cannot open the packet. I have to send it back to the manufacturer. This was how absurd the system was. Okay, that matter. It is something in the past for India, mostly. The amendments made sure that all states of India, all 29 states of India, have the same rules for access to essential narcotic drugs. Or this is a class of medicines that the new law brought in, essential narcotic drugs, or ENDs. For essential narcotic drugs, the list will be put up by the government. You need only the same rules. And if you go to the drug controller of your state and get approval as a recognized medical institution, you don't need any of these. Only one agency, single window. Apply to the drug controller. I'll tell you later how to apply. Apply to the drug controller. He is bound to give you a response in 2 months. That's the law. That's the rule. He gives you the approval as an RMI, and thereafter you order whatever opioid medicine you need from any manufacturer. That's the current rule. Shall I stop here to take any question? Have you understood how the system works? Let me see who is in front of me. Swami Pranagaji, where are you from, if I may ask? Would you like to unmute and speak?
Sir, I am from Coimbatore, Isha Foundation.
Oh, hi. So, what Isha Foundation has to do after you have completed the course is to have your attach your certificate of training, fill up the required form, and send a registered letter to the drugs controller state. Keep a copy with you. Open a new file. Keep a copy of everything. If he has not responded in 2 months, you will have to send another letter saying, we should have got your response by 2 months according to the rules. We haven't got it. Can you please give it immediately? And usually that fetches a response. So once you get that approval for Isha Foundation as a recognized medical institution, done. You just attach it and send an order in the prescribed form to the manufacturer. Is that clear?
Yeah, it's clear.
Dr. Laishram Purnima Devi, where are you from, if I may ask you?
Sir, I'm from
Your voice is breaking. You are from? That's
I'm
okay.
from Manipur, sir.
Oh, Manipur. Okay. Manipur also seems to be more or less familiar with the new rules. In some states, the doctors are not quite, the officials are not quite aware of the new rules. And there we have problems. But the majority of states, it is done. Okay, maybe you will have more questions and I'll certainly take those questions towards the end. One thing you will have to understand when we try to understand the rules and the laws, there is a difference between law and rule. A law is something that is created by an act of parliament, either of a act of either the parliament or a legislative assembly for the state. Legislative assemblies cannot pass laws like this, but that is the law. Rules are created by an executive order to implement the way the law is to be implemented. In our case, it is a Department of Revenue. Department of Revenue sets forth a list of rules. So for each law, the application when you join for medicine, you never thought you would have to hear about laws and acts and things like that. So by a rule published by the Department of Revenue, they have said, okay, these medicines are considered essential narcotic drugs. If they want to add 2 medicines, they can just give it by another government order. You don't need the parliament for that. Of the medicines that we are interested in, morphine, fentanyl, and methadone, all three, step 3 opioid medicines, step 3 analgesics. These are called essential narcotic drugs. And to stock them and dispense them, you will need to be a RMI, recognized medical institution. Okay. I can't read your expressions. I don't know whether I am getting through to you or not. Dr. Ajinisha, understood?
Yes, I was talking actually, my mic was on mute.
Sorry,
Hello?
Ajinisha,
Can you
what
hear
did you
me?
say?
Can you hear me? Like I was
Yeah.
answering a question, but my mic was on mute. I didn't realize that.
No. Did you understand what I said? Is this clear?
Yes, about the law. Yes,
Law and rule?
yes.
Yes. Okay. Thank you, Ajinisha.
Thank you.
If the drugs controller is to approve you as an RMI, one doctor, MBBS or BDS, has to be there in the institution. And this doctor with training in pain management, for example, this course, must be named the doctor in charge of RMI. Dr. Ajinisha, where are you coming from?
I'm from Kerala, sir. I'm from Calicut.
Okay, Calicut. Okay. Dr. Rajendran Nair, where are you from?
Yes, sir.
Where are you from?
I'm from Trivandrum, sir.
Okay. Yes. Rasmi KP, where are you from? Dr. Rajendran, I didn't recognize you for a second. Now I understand who I am talking to. Rasmi, where are you from? Arpita Tiga. सो गई क्या?
Dr. Rashmi KP or Dr. Arpita?
Sir, I'm from Wayanad. Sorry, I forgot to unmute my phone. Hello, sir.
So, who is
Hello?
speaking?
That was
Sir, I'm
Dr.
Dr.
Rashmi.
Rashmi.
Rashmi, where are you from?
Sir, I'm from Wayanad.
All Keralites, all Malus. I was just trying to find out people from other states and whether they have morphine, whether they are having a problem. Somebody from outside Kerala, would you like to speak up?
Sir, I am from Gurgaon.
Okay. Dr. Shweta. Dr. Shweta, where do you work? What's the hospital?
Sir, Palam Vihar Metro Hospital in Gurgaon.
Do you already have these essential narcotic drugs like morphine, methadone, and fentanyl?
No, sir, we have difficulty obtaining morphine and methadone. Fentanyl we are getting only for OT uses because there are some restrictions here as well.
So you already have morphine and methadone?
Sir, we don't have morphine and methadone. We have fentanyl.
So Dr. Rashmi, when the course is over, when you get a certificate of training, you have to assume charge of the RMI for stocking and dispensing, because your training will be necessary for the hospital to get it. And thereafter, we'll explain the process of how you can get your institution recognized as approved as an RMI. The rules do not specify what kind of training is okay. In Kerala, the drugs controller has given a government order approving of online training as adequate. So maybe you can attach it if there is a question, and otherwise it will be drug controller's discretion to decide what training is okay. Mostly people do not have a problem with virtual training. Now there is something which makes it even easier for government hospitals. Government hospitals do not even have to apply to be for approval as an RMI. They are considered to be deemed to be RMIs. They do not need a prior approval. But they must ensure all documentation. They also, they cannot just get the medicine and do it without documentation. They also, government hospitals also have to submit the consumption data to the drugs controller every year. Just like a private institution or a non-government organization like ours, government hospitals also have to do this. Only thing is, they do not have to apply for approval as an RMI. But the most important thing, doctors, is that we must ensure proper documentation. This is vitally important. If you do not establish a good system, suppose some medicines get lost. It can be injectable, it can be oral. Suppose some person who is angry with you or angry with the hospital or is desperately in need of money takes a carton of the medicine and sells it outside and gets caught, your institution will suffer. The whole palliative care movement in the country will suffer. And you will and I will feel responsible for creating a problem for the society. Therefore, this documentation is vitally important. I've just shown a picture of a page from our stock register. Remember one thing, you need 2 prescriptions. One has to go with the patient. One has to be in your institution. Our second prescription that we keep is just in the case file, which we stock. One goes out with the patient. In addition, we write on the case sheet on the register, the first several columns are for receipts. This says on the 11th of April from this manufacturer of this batch number of this date of manufacturer of this date of expiry, we got 24,000 tablets. We keep separate registers for different formulations. We have one register for 10 milligram morphine, another register for 20, another for 50 milligram tablets. We have yet another register for morphine injection. We have another register for methadone. We have another register for injection fentanyl. We have another register for transdermal fentanyl. That makes it easier. There is no law that they have to be separate. But even if it's not separate, it has to be separate pages. Then you give a serial number for our own purpose, give the date, say what is the opening stock, how much is there in the stock. These two numbers are written with a plus in between because they belong to different batches. It doesn't have to be like that. The patient's name is written, the register number is written, the quantity issued is written, and after issuing 35 tablets, how much do you have left is also written here. Girija Kumari got so much, 300 tablets, has this number, 300 tablets, and the stock remaining is so much. This is how we keep the register. So if you want approval as an RMI, you have to apply, as I said, by registered letter to the drugs controller. I say registered letter not because it is legally mandatory, it's always safer. If you go personally, I think it's a problem. You may come across some corrupt person in the whole office and they may want a bribe and they'll think you have a vested interest. I would recommend that you send it as registered letter and keep a copy. All the forms are given in the link that I have given. Sri Priya is going to share this presentation with you so that you will be easily able to find the rules. This is the Government of India Gazette giving the rules. And for Mallus and South Indians, don't be too scared by the Hindi thing. After the Hindi version, the English thing follows. And there, after explaining the rules, you will find that the various forms are given here. So you can just copy paste it and print it. These are the various forms for own purpose. This is what the manufacturer sends. This is the daily account that your pharmacy has to, or whoever is keeping it has to keep. This is the form that I showed actually, how you keep the daily stock. But though it is not given in a good order, look at this form. This is the form that you have to fill up to apply for approval as an RMI. This is a form you have to fill up also every year for submitting the data. Oh, no, not every 3 years for renewal. Name and complete postal address with telephone number, etc., etc. Who is in charge of the institution, medical superintendent or director or whoever. How many doctors are employed? How many patients are treated? They have put in all this. If you don't know the exact number, don't worry. Approximation will be necessary, say 20,000 plus. Who would be the doctor in charge? And the name is written here. If there are several people who have gone through the training, the names are written here. Number and date, the certificate of recognition, if this is a renewal application, is given here. And you say, if it was withdrawn at any time, you make a point. For most of us, it will be nil. And then in this form, the drugs controller will send you a letter of approval. If he finds a problem with your application, he will show the cause and send the response. So just to show some of the forms, I showed this. All the forms are shown there. There is also this document on our website. This is in Pallium India website. This is a document created by Dr. Nandini Vallat, an excellent document which may answer many other questions that you have. I'm not showing it, but it will be available to all of you. Once you get the approval as an RMI or recognized medical institution, there is a form given in that document. You place an order with the supplier. Depends on the hospital. If you do not have a relationship with if your hospital doesn't have a already established relationship with the manufacturer, they may want an advance payment. They will say pay so much, you pay it, and the medicine comes to you as registered parcel or courier. When it comes, you go back to your register, enter the receipt there. This is the process. This is where you may have more doubts. I stand by to answer the questions. This is the document that I showed you. The best practices for medical use of strong opioids, prepared by Dr. Nandini Vallat, and it gives the processes that we have to follow, etc. I'm not going into the details of that document now, but I'll stop here and take your questions.
We have no questions or inputs in the chat box. Does anyone want to share their inputs or ask queries at this point of time? If so, you can unmute and speak for yourself.
So is this directly supervised by the palliative care doctor or the hospital's procurement person who gets the other drugs can look after this also?
They can look after. See, in my institution, we have 2 pharmacists. We have 7 doctors. Officially, I am in charge. I am the one who has to sign the register periodically. Any doctor prescribes, the pharmacist dispenses. That's okay. But I am in charge. I will be the one to sign to make sure that the system functions. So, Dr. Femi, it's okay to leave it to the pharmacist. It's okay to leave it to the system. But you make sure that the process is followed, that somebody doesn't become lax in between. Because if we make a mistake, the whole palliative care movement will suffer tomorrow.
So also there was a mention in an earlier presentation about keeping it under lock if we have a very small setup.
Absolutely. However small your setup is, it still has to be kept under lock. Actually, when you apply, sometimes the drugs controller will send around a drug inspector for examination. He will ask for 1, your certificate of training, 2, whether you have a safe place to keep it. For example, I'll tell you, if you have a cupboard, you keep it in a cupboard with a glass case. It's not safe. Somebody may break open the glass cupboard. It has to be a steel cupboard. Generally, there is a convention. It's not there in the rules. By conventionally, drugs controllers are used to having double locking system. You know, you in your bureau, in your home, you have a cupboard, you have a shelf that you open with a key, and inside there is another small what do you call it? They say there's another compartment which you can open with a lock. That's the principle. For us, there is one lock for the room, there is another lock for the cupboard, and the key is kept with some responsible person, and the room is kept locked when you don't need it. In our place, the pharmacist keeps it. There is a small stock kept with a separate register in the ward for night use, but the pharmacist oversees it. That's okay. But I oversee it. I periodically check it.
Thank you, sir.
So, where are you from?
So I'm working in Uttarakhand. I'm from Trivandrum. I'm
Where, Uttarakhand, where, if I may ask?
Abudpur, sir. It's near Dehradun.
Okay. Okay. See you next time you come to Trivandrum, Femi. Or we see you in Dehradun. Anybody else? Any questions? You're muted, Dr. Shweta.
Sir, if somebody plans of opening a palliative care clinic on like in the initial beginning phase, even then the procedure would be same.
Same procedure, same form. You fill up a form, they will ask, what's your estimated quantity? You don't know how many patients you will get. Shweta in the first year may get 5 patients or 5,000 patients, we don't know. So just write half a kilogram or something like that, or approximate number. Yes, the forms need to be filled up.
And sir, will the online training be sufficient in Haryana as well?
There's a catch, Dr. Shweta. Only the Kerala Drugs Controller has issued this order. In other states, the rules do not say what training is appropriate. They have no mention. So generally,
But, since I am an anesthetist, so would it not be implied in my that I am already trained in narcotics?
honestly, Shweta, that will be dependent on what attitude the drugs controller takes. Many drugs controllers are very knowledgeable. They will know that in your anesthesiology MD, I am also an anesthetist. We don't learn about how the use of oral morphine, except in some institutions. So they may ask for another order, another training. That's possible. But I don't think you should go and ask them, hey, is my training appropriate? Just apply, enclose the training of a training certificate. Ordinarily, they approve it. If they don't approve it, Shweta has brought up this problem. Sometimes they ask for other questions. Femi, this happened in Uttarakhand only 3 years back. One institution applied for RMI status. They did not respond. So the doctor went and met the drugs controller. The drugs controller was very nice and immediately said, no problem, doctor, we'll do it. And then they got a letter saying, you submit the floor plan of the building and submit the certificate of registration with some government committee. What would you do? They are asking for things which are not in the rules. So what we did was, I requested the institution's permission to write to the drug controller. They were very reluctant. They thought if they will become enemy, the drug controller becomes an enemy, there will be a problem. I said, I'll show you the draft of what I am sending. So with their permission, I wrote a letter, registered letter, mind you, to the drug controller saying, I am writing on behalf of the WHO Collaborating Center for Training and Policy on Access to Pain Relief. While monitoring the progress in many states, I find that an institution in Uttarakhand was asked to submit the floor plan of the building and registration under national accreditation, something. I said, this is against the law of the land. The rules were amended and law was amended to facilitate access to opioids. And when we ask for any stipulation which is outside the needs of the rules, this is a violation of the rules. So please reconsider and this institution needs it desperately for treating poor people. Every delay means every day hundreds of people will be in pain. Please do the needful immediately. They got the morphine within a week. They got the approval within a week. I know it will not happen in every state. In West Bengal, we had a lot of problems. It went on for a year and a half, but we did not give up. We were persistent. I know that in Punjab it will be much more difficult. In states where there is already a perceived major problem of addiction, the problems are more. So, but the problems are more. We just put in harder work. That's all. We still have to do it. We'll continue. So, Dr. Shweta, you look a bit worried about this. Dr. Shweta, we are going to work together. And this is not only to Shweta, to everyone in this room. Except Dr. CY, where I will not be able to do anything directly. But if Dr. CY says, which city are you in, Dr. CY?
I'm in Selangor, actually semi rural area.
Okay.
Yeah.
So
Selangor is nearby Kuala Lumpur. Yeah.
So you have no problem with access to opioids, do you?
Yeah, actually, my problem here is not that much of a legal problem. It's more administrative problem because I am actually pioneering to start a palliative care in the government setting clinics. So in the clinics in government setting, we don't have much of morphine except oral morphine, syrup morphine. Other than that, I don't have any fentanyl or slow release morphine. But good that is that I collaborate with hospital where the palliative physicians supply me, they borrow me the medication temporarily while I'm running the service.
Okay. So in Malaysia, when people have problems, I usually introduce them to Dr. Richard Limbun Yong.
Yes.
He is a phenomenal person. He being in charge of palliative care at the government, usually he is able to pull a lot of strings and get things done. But for everybody else, let me tell you, for including to Dr. CY, therefore, let us work together. Many of you will come across problems. It is not going to be easy in every state. Dr. Banerjee, Dr. Lystrom, Dr. Meenu, everybody, whichever state you are in, when you have problems with access to opioids, please do not work alone. It is too much of a bother for you. You are busy clinicians. You have 100 things to do. Allow us to help you. Allow us to work with you. Because we are used to doing this, because over how many years? 26 years, we have walked this path. We know how many problems can be there, and we know how, with patience and persistence, they can be overcome. So allow us to work with you. Do please email us when you face a problem with opioid access or when you have a doubt.
So actually, I haven't figured out how to use my knowledge of palliative care because I am working in a situation and scenario which is inside an army hospital. So there is no palliative care at all here in army hospital, and even in the in this town, small town. Initially, I was thinking of opening, a personal clinic sort of thing, but I'll not be able to do it alone. So I really haven't figured out how to use my knowledge. I have done a course in diploma in family medicine and handling geriatric and aged people for more than 15 years. And with good clinical base of handling all chronic diseases. This will be extremely helpful for me, but individual level, I don't know how I'll move. How much I will be able to use this knowledge.
Dr. Banerjee, you don't know how to, right, you are a bit apprehensive about the problems in front of
Yeah.
you, let us first take a decision. What's your first name, Dr. Banerjee?
Krishna Priya.
Krishna Priya. That's so much friendly to call you Krishna Priya. Krishna.
Thank you, sir.
Krishna, the first thing
Sir.
is, we are going to do it.
I love to join you, sir.
No, we are going to do this. In that's something you make up in your mind. You are now wondering, how will I do this? Will I be able to do this? You will be able to do this. The law permits it. It's up to us to work together to make it happen. Armed forces hospitals have been difficult. But recently, I don't know if you know this, 2 armed forces hospitals in the country. The first was Calcutta.
I belong to Kolkata.
The second was Delhi. These 2 institutions have already started palliative care. And Shalini, you are here.
Yes, sir.
Shalini, thank you for making yourself visible. Shalini, you have met this group already?
Yes, sir. We talked about organizing palliative care services.
Oh, very good. So then you know Shalini. Shalini is the person who is going to work with you anywhere in the country. She has a team of several officers, project officers working. So Krishna,
Sir.
Shalini, and all of us stand by to assist you. But as I said, Krishna, please do not feel disheartened if your first attempt is not a success. You may find it difficult. Remember, all the easy things have been already done by somebody else. The difficult things are left behind, and they are the worthwhile things to do. Imagine 2 years from now, what a pleasure it will be to sit back and think on your weekend, because of me in Kolkata, 452 people have got pain relief. That's a very satisfying thought. That's what we'll work towards. Any other question? Dr. Vignesh Sunil, where are you from?
So I'm from Kerala, sir.
Okay.
Ernakulam district.
Ernakulam. Okay. Delnas Dabar. Sorry if I'm mispronouncing your name. Delnas.
Yes, sir. Yes, sir.
You are certainly not from Kerala. Or are you?
No, sir. I'm from Mumbai.
Okay.
Mumbai, sir.
Mumbai. So Maharashtra generally has the problem more or less sorted out. What hospital are you working in?
I'm working with Masina Center, the Onco Center, and Parsi General Hospital.
Do you already have a palliative care unit there?
No, sir. Not yet.
So if others have questions, we'll answer them. But till then, can I ask you another question? So what are you going to do to get morphine?
Sir, actually, the BND Onco Center, where we are seeing few cancer patients, whenever we require morphine, we give them 3 prescriptions. One is always with the patient, one is with us, and one they give it to the pharmaceutical people. The Masina Hospital Pharmacy has a right, so they sometimes serve them with morphine. Ventolin is available, morphine is a problem, and methadone, sir, I'm not yet used.
So, Delnas,
Yes, sir.
I think your voice broke in between. Delnas, I am thinking, everybody, I am not speaking only to Delnas. Please listen to me, because you may be the one to treat me when my time comes. Who knows where I'm going to be? I may find that I am the patient of Dr. Mohit Kumar or Dr. Alma Rachel or Delnas. And think of me as a patient with advanced cancer, mind you. I'm in pain, I am suffering, I am coming to you. I have spent 2 hours on the Mumbai roads to get to you. I waited for you for 45 minutes till you became free, and you are giving me a prescription and asking me to go to another place. At that point of time, when a patient has limited time left, they shouldn't be made to run around. I'm glad you have the solution right now, but maybe someday, if we think from the patient's point of view, having to go from place to place looking for the medicine, and you go there and somebody says, oh, no, no, we have closed, come tomorrow, can be horrendous. So maybe we should work together, Dr. Delnas, to make it available where you are. Just give it
Yes.
a thought. Anybody else, any questions? Haifa Salim? Haifa, where are you from?
Kerala, sir.
Which place?
Karunapalli.
Okay, okay. So you work with the government or private side?
Government, one KSSM project is the Vayomitram project. I work there, sir.
So Kerala government, Department of Health Services has included morphine tablets among essential medicines. So the process is very easy for you. You can just order the medicine from Central Drugstore of DGHS. Only thing is, maybe they'll ask for some forms and your certificate, etc., which you will have to provide. But more importantly, please make sure of the documentation. Does anybody have any other question? Dr. Deepak Dash says, write prescription and then patients take it from pharmacy. Dr. Deepak, let me ask you, is the pharmacy in your hospital or outside pharmacy? Outside pharmacy. That's okay. The one problem that I find is pharmacies generally keep the most expensive formulation, because that's where the profit margin comes in. So patients may be paying unnecessarily, but if it is not too far away, that's okay. Dr. Deepak, where are you from? If you, you're not very audible. Sorry, the line was bad.
Sir,
You can
he's from
type.
Sir, he's from the same hospital.
Okay.
Dr. Shubroto Goswami is from.
Okay.
Yeah.
Okay.
Yes, I called it out.
Yeah.
Yeah.
So if it is not too far away and accessible easily, that's okay. You may still have some problem with the injectables for the patient to get it from a private site, but let us talk about it later. So Shalini has put in some message to Dr. Krishna Priya Banerjee. Thank you, Shalini. Sri Priya, so before that, Shalini, you have anything to add or make a comment?
So we would love to support you, as we have mentioned to all the doctors earlier. We have the regional coordinators for each region. Please let us know. Just share your number here on the chat and we'll get back to you and help you with whatever kind of concerns that you might be having for your state. Because our regional coordinators are very accustomed with what the problems of that state, like what the drug controller is. If there is a problem with the drug controller office, then they know the local partners who has influence on the drug controller, or the who can help you move further your application, or who can bring resources which is available in your city together and to help you. So just taking an example of Dr. Banerjee, I think I must have mentioned in our last session also that Mr. Shantanu Chakravarti is working closely with CNCI, and they have opened up a hospice, a big palliative care center in Kolkata. And there are a lot of other groups which are working. Eastern India Palliative Care also is working. So whatever is the possibility for you, because I know within your organization, because it's a defense forces, there are a lot of bureaucracy involved, a lot of permissions to be taken. It might not happen, but the urge to serve and urge to work for palliative care, we can provide a lot of other platforms where you can go for it. So whichever we can work with you, we would be happy to. Just a message to everyone. Yeah. Thank you, sir.
Thank you, Shalini. Sripriya, we have a case presentation today.
No, sir. Time is yours till 6:30 if you want.
So sorry.
So you have time till 6:30 if you want.
No. I am fine. But you said there is a case presentation, right?
No, sir. For opioid availability, generally we don't bring in case presentations.
Okay. Ladies and gentlemen, this is some kind of a record. All the questions are over. We have finished the discussion on this subject. We are near the end of the course. So therefore, now let us open the discussion to any question that you wanted to ask about palliative care. Not only opioid access, anything.
Sir, I want to know your experience about something like what I'm feeling about palliative care. Normally the multi-specialty hospital, corporate hospital, all those hospitals, they are trying to drag money, squeeze money from the people. And they are actually not allowing, not clearing the picture of the patient. Most of the time we get that end of the time the patient will suffer, they will spend a lot of money, and after that they will be left. And there are very few state, I don't know, they have adequate palliative care centers. So this is really a very big challenge. And even those who are learning also, without dedicated people, is it possible? It's more like a philosophy than to active participating thing.
Krishna,
So
thank you for the question. Very real problem, no doubt. Is there anybody who wants to react to that? You have a solution to suggest? Krishna, in India, 65% plus of all healthcare is on the private sector. That is not all on the corporate sector. Some of it is on charitable sector also. But at least 50% of all healthcare is on corporate side, where mostly the focus is on profit. All the problems that you mentioned are there. True, no doubt. And all of a sudden, if you want all corporate hospitals to become compassionate institutions, not realistic. Krishna, change is not easy. Don't expect change to be easy. There will be difficulties. So we will try to change what can easily be changed. There is a huge burden of pain in the country. There is, okay, at least 35% of healthcare in the government and or at least 40% of government and charitable sector. Can't we start with that? Let us start by creating a change there. And one thing that we will remember, I want you to remember this, 29 years back, when we started our palliative care work first, there was a lot of antagonism. People were calling us mad. You know what the saying is? First they ignore you, then they laugh at you, then they fight you, and then you win. All these will happen. But what I'm saying is, immediately don't start with the most difficult. Initiating a change in corporate sector is harder. Krishna, the easiest thing for you is to make a change in your own division, your own institution. And 5 years from now, the change will be visible. Somebody who ordinarily runs to the most expensive corporate hospital will hear about his cousin's experience in your hospital and will leave them and come here. And gradually the news will spread. One of the things that we will have to learn to effect change is never try with the hardest possible thing. Try with the easier things. Others will change. One thing that is changing corporate sector is people working abroad go to corporate for the treatment of their mother or father or a cousin, and they don't see pain being treated. And sometimes they ask questions. Look, what are you doing? This is not the way medicine is to be practiced. I am working in MD Anderson Cancer Center. We wouldn't allow anybody to be in pain like that. When people like that ask questions, things change. So everywhere things will change. But the problem that Krishna mentioned, that healthcare is aimed at profit, is true for most of the world today. But I am happy that at least 35% of healthcare is not in the corporate sector. That's where we can make a change. Who's going to ask the next question? So many people have not spoken to me today. Who is signed in as Oppo A5s? You want to make yourself visible or poor connection? Melvin Syriac, where are you from? Melvin Syriac is not only invisible, he is also inaudible. Mary Susie, where are you? Where do you work?
I'm working in a missionary hospital in Orissa.
Which place?
Orissa.
Which place? Which city or with?
Nabarangpur.
I don't know Nabarangpur, but what kind of institution do you work in?
Sir, it's a private hospital only. Private secondary level hospital only, sir.
Okay. Do you think it's a charitable hospital or a totally corporate hospital?
It's a charitable hospital, sir.
So what are you going to do there? If I may ask you, what do you plan to do?
Sir, first thing is in the hospital, I don't know whether I can start up a palliative unit. I have to talk to the MS regarding it. And first thing is that. Second thing is I am planning to do my PG also. Along with, after doing PG, I would like to continue working with the palliative unit, sir.
So I think Krishna was also asking this question. I don't know if it was Krishna. You are one person now. Mary is one person. It's difficult without companionship.
Yes,
Maybe,
sir.
Mary, you have a weekly departmental meeting. hospital meeting, case discussions, academic
No,
sessions?
actually, no. Here we don't have.
Talk to a few people who are compassionate.
Yes, sir.
Get a few people together.
Mm.
Then go and talk to the medical superintendent. Don't ask for too many things. Ask only for permission to do this alongside the rest of the work. Explain the importance. And if the medical superintendent says no, say yes, sir, and come back.
Mm.
Don't give up. Go
Mm.
back to this person next month with the story of your patient. Here is the patient. How can I treat this person? Sir, please help. Give us one opportunity to make this happen. And you said you don't know whether you can do it. I think you change the mindset to I am going to do it. People
Yes, sir.
deserve help. They have a right for treatment of suffering. The system is not allowing to do it. We all will be agents for change. Best wishes for your PG, Mary.
Thank you, sir.
Abhishek?
Yes, sir. Good evening, sir. I
Good
am
evening.
Dr. Abhishek, from Wayanad, sir. From Wayanad
Which-
Institute of Medical Sciences.
Which institute?
Wayanad Institute of Medical Sciences, sir. DMN.
Oh, that is in Calcutta.
Yes, sir. Yes, sir.
Okay.
Aster Wayanad, sir.
Okay, Aster Wayanad.
We have a rehabilitation center which looks into the non-cancerous palliative care. And there is good scope in our institution to start palliative care medicine. And we are still in the process, sir. I think there will be a positive response. I feel our institution will actually support because we have a team of doctors who do house visitations, and we have a lot of volunteers available to take up the work of palliative care medicine. So I'm pretty hopeful. And this course has provided me a good insight into the things that has to be done. And I think things can be implemented in our institution.
Just delete 2 words. Just delete the words I think.
Okay,
Things
sir.
can be implemented. There may be obstacles. Things can be done.
Thank you
This
so
is
much.
something that needs to be done. This is Dr. Asad Mupen's institution, right?
Yes, sir. This is
Okay,
a yes.
Oh, Aster who is going to get a palliative care medicine department. Fantastic.
Yes.
Anyway. Who else? Alma Rachel.
Good evening, sir.
Where are you from?
I'm from Tiruvalla, Kerala.
Can't hear you, Alma.
I'm from Tiruvalla, Kerala.
Which institution?
Parumala Hospital, St. Gregorius Medical.
Parumala's palliative care unit, it was there, but it's not there anymore, right?
Yeah. I just recently joined here. I don't know much about the setup right now.
Alma, if I am not mistaken, for many years, Parumala Hospital had a palliative care service. And when a doctor went abroad or something, it stopped. So, best wishes, Alma, for starting this.
Thank you, sir.
Meenu? Meenu, where are you from?
Sir, I am from Kerala. Currently, I am working as an assistant surgeon in FHC, Kannur, one of the FHCs in Kannur.
What obstacles, what barriers do you find to doing some of this work?
Sir, actually, under LSTD, we have a running palliative care program. There is a designated palliative nurse, and we have some drug supply, but not morphine. But in our FHC, there is not much patient who is taking morphine, and only one patient is taking morphine for cancer pain that they are getting from DH District Hospital Kannur. So we are not having much problem in this palliative care because we are having regular home visits and all.
Meenu, when you say we are not having much problem, think of the patient to go, having to go to somewhere else to collect.
This morphine, sir. Regarding morphine,
yeah.
their bystander has to go and collect from DH
Yeah.
Kannur. We are not providing it actually from.
So, Meenu,
Yes,
are
sir.
you not going to provide it in future?
Yes, sir. I will consider.
Okay. I mean, Meenu, I think it's our ethical responsibility. There must be numerous people in pain in the locality. Some who won't go to you and goes to the district hospital. And I've seen so many families where there is just an old man and an old woman. Children are all working, one in Dubai and one in Philadelphia. And this woman has to leave the man and travel for the first day to another city to get the morphine. That's horrendous. I have been troubling people a lot. Anybody wants to ask a question or offer a comment?
Excuse me, sir.
Yes. Haifa.
Sir, if you're in the government, yeah, sir. If like my husband is working as an assistant surgeon in CHC Mudugulam, so basically there is no palliative care setup in that hospital. So actually he is interested, and they don't have access. They are not. They're not able to write like prescription like morphine. They're not able to supply. So how do we?
So is it Dr. Salim? What's the name of your husband?
Shibu Khan.
Dr. Shibu Khan does not have training in pain management, right? A course
No,
like
sir.
this?
No, no, sir.
Haifa, I strongly recommend that he gets that training, because in MBBS, you and I have not been taught how to do it.
No, sir.
Get the training, get that certificate, and then let us work together to make it happen there.
Okay, okay. Thank you, sir.
Okay. Anybody else? Sri Priya?
Yes,
I've
sir.
troubled everybody enough. I'm glad we had all this time. I got to know so many people. I did not get to know everybody, but I got to know so many people. But thank you, everybody. Sri Priya, I have concluded what I have to say.
Thank you so much, sir. And by the way, your words are never a trouble for us. Like I would believe that everyone will agree to that, because words of wisdom don't come our way every day. So whenever it
Thank you,
comes,
Sri.
it is our pleasure and privilege, sir. Thank you
Thank
for
you.
joining us. We do, as a personal thing, as a person seeing you almost regularly, I do understand your busy schedule, and extremely happy that you could find out time for this cohort to interact with us, keeping apart all your busy calls and messages. Thank you so much for that. So with that note, and also Shalini ma'am, sorry, I forgot to introduce you at the initial stage. So sorry. Shalini ma'am, thank you for being part of this session as well. And thank you everyone for joining us. With that note, this is Sri Priya along with Dr. M. Rajagopal and Ms. Shalini Ajay signing off from the Tips Echo Hub. See you in the next session. Till then, everyone, take care, be safe, be happy. And please don't forget to leave your feedback. Bye-bye.
Thank you.